Hello, Abby. My name's Amy. May I examine your eyes?
Yes.
There are many useful signs on examination of the eyes. An exhaustive list is in the book. Look at the head and eyelid position and consider the parts of the eye in turn. Look for proptosis or forward bulging of the eyeball from above. Now we test visual acuity.
Do you wear glasses?
No.
Ask the patient to use their distance glasses if they use them.
Please cover your right eye.
Ensure good ambient lighting. Use the chart at its specified distance and ensure that it doesn't move. Ask the patient to cover one eye with a card and read from the top down until they can no longer distinguish the letters.
Please cover your left eye.
If the patient cannot read down to the bottom line, use a pinhole. If they can't read the top line of the chart, bring the chart closer until they can and record this distance. Repeat this process for near vision.
Please cover your right eye.
Consider the lighting again and the patient's reading glasses.
Hold this at a comfortable distance and start reading from the top paragraph.
The card is printed with prose in type of various sizes. Record the smallest size that can be read accurately.
Please cover your left eye and continue reading.
And better lighted than those of any metropolis in Europe.
Thank you.
To test the patient's visual fields, sit directly facing the patient about 1 meter away.
Please keep your head still and look directly into my eyes.
Test for a homonymous defect with all 4 eyes open.
Please tell me when you see my finger moving.
Now.
Hold your hands out to their full extent and wiggle your fingertip. Ask the patient to indicate when they see it move. Do this at 2, 4, 8 and 10 o'clock. Test for sensory inattention.
Please point to the finger that you see moving.
Both you and the patient should keep your eyes open. Check both sides at the same time.
Please cover your right eye.
Test peripheral visual fields in one eye at a time.
Please look directly at my eye.
The patient covers one eye and you shut your opposite eye.
Please tell me when you see my finger moving.
Now.
Test each quadrant separately and compare your visual field with the patient's. You need to be seated close together so that you can hold your finger in an equivalent position for both your and the patient's eye.
Please cover your left eye. Please look directly at my eye and tell me when you see.
Start with your finger in the periphery out of view and wiggle the tip. Bring your wiggling finger along the diagonal towards the centre of vision. The patient should indicate as soon as they see it moving.
Now. Now. Now.
Next, we test the central visual field using a red hat pin.
Please cover your right eye.
And you close your left.
What colour is the hat pin?
Red.
Test for colour desaturation.
Please keep your head still and look directly at my eye. Please tell me when the pin disappears.
Make a rough map of the patient's blind spot and compare this to your own.
Please tell me when it reappears.
Now.
Can you see it here?
Yes.
And here?
Compare perception of the hat pin in the 4 quadrants of the visual field centrally. Ask specifically about colour desaturation. Next, we examine the eye movements. Hold your finger at least 50 centimetres away from the patient.
Please keep your head still and look at my finger. Please follow my finger and tell me if you see double at any time.
Move your finger to each side and up and down, tracing the letter H in the air. Look for any divergence of the gaze, which you would see, or double vision, which the patient would report. You may also detect abnormal patterns of movement such as nystagmus. Examine the pupils for shape and symmetry.
Please look straight ahead.
Take account of the ambient lighting.
Continue looking straight ahead. I'm going to shine a light in your eyes.
Bring a bright light from the side to shine on the pupil. Look for constriction of the illuminated pupil, the direct light reflex, and of the opposite pupil, the consensual light reflex. Look at the accommodation reflex and gaze convergence.
Please focus on a point on the far wall.
Present an object at about 15 centimetres.
Now look at the tip of this pen.
You should see the eyes converge and the pupils constricting as the eyes accommodate. Use an ophthalmoscope to look at the retina and optic nerve head.
I'm going to have a look at the back of your eye.
Start with the patient's right eye. Hold the ophthalmoscope in your right hand and use your right eye. Find 0 and rotate the lenses clockwise to lens 10.
Please look down.
Gently retract the upper eyelid.
Now focus on a point on the far wall.
Start at a distance of about 10 centimetres and bring the red reflex into focus. The cornea, iris and lens can be seen and any opacity will appear black. Now come close to the patient's head such that you touch the hand you are resting on their forehead. As you do, rotate the lenses anti-clockwise until the retina comes into focus.
Please look up.
By asking the patient to divert their gaze and making your own movements, systematically examine the retina
And left.
finishing with the fovea.
Please look directly at the light. Thank you. Hello, Abby. My name's Amy. Please may I examine your face?
Yes.
First, test light touch sensation.
I'm going to touch your face with some cotton wool. Please could you close your eyes and tell me when you feel me touch you?
On both sides, test the 3 divisions of the nerve, the ophthalmic, maxillary and mandibular.
Now. Now. Now.
Repeat the test for pain sensation.
I'm now going to touch your face with a small pin. Please close your eyes and tell me if you feel it sharp.
Carefully test each of the 3 areas on both sides. Be aware that brainstem lesions may cause sensory loss in an onion skin pattern. Carefully dispose of the sharp.
Yes. Yes. Yes.
Use an orange stick to test touch on the anterior 2/3 of the tongue.
I'm going to touch your tongue with this. Please close your eyes and stick out your tongue. Thank you. Do you feel it the same on both sides?
Yes.
You can also ask the patient to indicate with a hand when they feel you touching them. Assess the motor function now. Look for wasting in the muscles of mastication.
Please clench your teeth.
Feel the bulk and contraction in the masseters.
Please open your mouth against my hand.
Carefully provide resistance to mouth opening, testing the pterygoid muscles. Next, test the corneal reflex. Draw out a wisp of cotton wool and dampen it to form a gentle point.
I'm going to gently touch your eye. Please look up for me.
Gently depress the lower eyelid and lightly touch the edge of the cornea. Look for direct and consensual blinking. Lastly, the jaw jerk reflex.
I'm gently going to tap your chin.
Ask the patient to let their mouth hang loosely open. Place your forefinger across the midline between the lower lip and chin. Look for reflex closing of the jaw. An absent or minimal response is normal.
Thank you.
Hello, my name's Ben. Do you mind if I examine you?
No.
Just look straight ahead for me.
Inspect the whole face for asymmetry, including differences in blinking or eye closure.
Keeping your head still. Can you look up towards the ceiling and raise your eyebrows?
Look for wrinkling of the forehead.
And now can you show me your teeth like this?
Again, look for asymmetry.
Now close your eyes and don't let me open them.
Test power by gently trying to overcome eye closure.
Now can you blow out your cheeks for me, please? And hold them out as I try to press them in.
Try and push air out through the patient's lips.
Thank you.
Hello, Abby. My name's Amy. Please may I examine you?
Yes.
Stand behind the patient for the whispered voice test.
I'm going to whisper in your ear. Please can you repeat after me what I say?
Mask hearing in the contralateral ear by rubbing the tragus. Use a variety of numbers and letters and perform the test in a quiet room.
I'm going to do the same in your left ear.
Start at about 15 centimetres. Hearing a whisper at 60 centimetres approximates to unimpaired hearing. Hearing loss should be formally measured with audiometry. Use a tuning fork to help differentiate conductive from sensory neural hearing loss. First, Rinne's test.
Can you hear this?
Yes.
Tell me when you hear it stop.
The base of the vibrating tuning fork is gently pressed against the mastoid process.
Can you still hear it?
Yes.
This demonstrated that air conduction is better than bone conduction, which is normal. Air conduction relies on the function of the outer and middle ear.
Again, can you hear this?
Yes.
Tell me when you hear it stop.
If sound transmission through bone is greater than that through air, then the test is said to be negative. This indicates conductive deafness. For Weber's test, place the fork in the midline.
Does this sound louder in either ear?
Normally, the sound is described in the middle and heard equally in both ears. Interpretation of both tuning fork tests is more subtle than it initially appears.
Forward for me.
The Dix-Hallpike manoeuvre can elicit positional vertigo due to vestibular disease. This vigorous manoeuvre is not suitable for all patients. When the patient lies back, the head should overhang the edge.
I'm going to lie you down rapidly and turn your head to the side. Please could you look straight into my eyes?
The patient's head should extend 30 degrees beyond horizontal and rotate 45 degrees to one side.
Do you feel dizzy or sick?
No.
Watch the eyes carefully for nystagmus. It may take 20 seconds for this or symptoms to occur. The pattern of response can differentiate between a lesion in the inner ear or central nervous system. Repeat the test, turning the head to the other side.
Thank you.
Start with the glossopharyngeal and vagus nerves.
Could you cough for me, please?
An effective cough requires vagus nerve control of the vocal cords, as does producing a note.
Open your mouth for me, please, and say ah.
Look at the movements of the palate and uvula using a torch. If the palate is weak, you may be able to make air escape through the nose.
You blow out your cheeks for me, please. Just going to try and squeeze them in.
Consider using the water swallow test in fully conscious patients before moving on to the accessory nerve. Inspect and then palpate the sternocleidomastoid muscles, looking for wasting or hypertrophy.
And can you look over your right shoulder for me, please? And over your left shoulder.
Carefully resisting the movement with your hand.
And swing your legs over the side of the bed.
From behind the patient, inspect and palpate the trapezius muscle, looking for wasting or asymmetry.
I'm now going to feel your shoulders. Shrug your shoulders up and stop me from pushing them down.
Again, test power against resistance.
And pop your legs back up.
Next, examine the hypoglossal or 12th cranial nerve.
Can you just open your mouth for me, please?
Look at the tongue at rest for wasting, fasciculation, or involuntary movement. Use a torch if necessary.
And stick your tongue out.
Look for deviation or involuntary movement.
And move it from side to side.
Demonstrating active movements.
Pop your tongue back in and press it against your cheek. Stop me from pushing it in.
To test power in the tongue muscles.
And the same on the other side.
Then test lingual speech.
And now say, yellow lorry.
Yellow lorry.
The swallow test is also relevant.
Hello, Abby. My name's Amy. May I ask you a few questions?
Certainly.
How did you get here today?
Well, I was going to walk, but as it was raining, I decided to take the bus.
Have you been here long?
No, not really. Only about 10 minutes.
Could you repeat after me? Yellow lorry.
Yellow lorry.
Baby hippopotamus.
Baby hippopotamus.
The Leith police dismisseth us.
The Leith police dismisseth us.
Please could you count to 30?
1, 2, 3, 4, 5, 6, 7, 28, 29, 30.
Please could you cough? And say ah.
Ah.
Could you name these 3 objects for me?
A pen. A coin. A watch.
I'm going to give you an instruction. Please wait until I've finished speaking before you carry it out. Could you take a piece of paper, fold it in half and place it under the journal? Please repeat after me. Today is Tuesday.
Today is Tuesday.
Could you read the first sentence on this page?
October the 9th is World Sight Day, an annual opportunity to recognise the impact of blindness and to draw attention to what can be done to improve the lives of those with partial or complete visual loss.
Please could you write a sentence? Thank you. Hello, Omar. My name's Amy. Would it be okay if I examined your ears?
Yes.
Inspect the pinna, noting its shape, size and any deformity. Gently assess for tenderness by pulling on the pinna and pressing on the tragus.
Is this sore?
No.
How about this?
No.
Inspect the meatus. Is there evidence of previous surgery? Select the largest speculum that can be inserted comfortably and explain what you're going to do.
I'm going to look inside your ear now.
Get a comfortable grip of the oroscope and rest the ulnar border of your hand against the patient's cheek. Gently pull the pinna to straighten the canal.
Thank you.
To test for meningeal irritation, look for neck stiffness and Kernig's sign.
Get you into the right position. I'm going to take away the pillow and put the bed flat.
Make sure the patient's lower limbs are exposed and fully extended.
I'm going to lift your head.
Lift the occiput with your fingers and use the ulnar borders of your hands to feel for neck spasm. Gently flex until the chin touches the chest and hold the position for 10 seconds.
Now I'm going to lift your leg.
For Kernig's sign, flex one lower limb at the hip and knee with your left hand on the medial hamstrings.
And I'm going to straighten it.
The sign is present when the extension is resisted by spasm in the hamstrings. There may also be reflex flexion in the opposite limb. Kernig's sign is not present in local causes of neck stiffness such as cervical spine disease or raised intracranial pressure.
Thank you.
Hello, Omar. My name's Ben. Do you mind if I examine your neck?
No.
Can I ask you to take your top off, please?
The patient should have the neck and upper thorax exposed and be seated. This is not how to examine the neck after an injury, and take care if there is any other potential cause of instability, such as rheumatoid arthritis. Inspect from in front and behind and note the posture of the head and neck. Palpate the spinous processes from the occiput to T1. T1 is normally the most prominent.
Tell me if it's sore at any stage.
Next, feel for tenderness in the paraspinal soft tissues and then in the supraclavicular fossae for cervical ribs or enlarged cervical lymph nodes. Feel the structures in the anterior neck, including the thyroid gland. Check active movements.
Could you place your chin on your chest?
The normal limit is 80 degrees of flexion from the neutral when the chin touches the chest.
And now look up at the ceiling.
In extension, the normal limit is 50 degrees from neutral.
Now can you place your right ear on your right shoulder?
For lateral flexion, the normal limit is 45 degrees.
And the left ear onto the left shoulder.
In each direction, so the total arc is 90 degrees.
And now can you turn your head to the right, looking over your right shoulder?
This is lateral rotation.
And do the same on the left-hand side.
The normal range is 80 degrees in each direction.
Thank you. Hello, Omar. My name's Ben. Do you mind if I examine you?
No.
First, make a thorough inspection. Look for deformity. The patient should be comfortable and adequately exposed. Get good views from in front and behind the patient, including the axillae. The abnormal contour of posterior dislocation is best seen from above. Is there evidence of swelling or muscle wasting? Consider the size and position of the scapulae.
Can I ask you to stand up and lean against the wall for me, please?
Pressing against a wall can elicit winging of the scapula, seen after paralysis of the serratus anterior.
That's fine. Remain standing.
Palpate along the clavicle from the sternoclavicular joint to the acromioclavicular joint.
Let me know if it's uncomfortable at any stage.
Clavicular fractures and acromioclavicular joint injuries are accompanied by deformity and local tenderness. Also palpate the acromion, the coracoid process and the scapular spine. Test for tenderness of the biceps tendon in the bicipital groove and of the supraspinatus tendon. Hyperextend the shoulder to bring the supraspinatus tendon anteriorly out from under the acromion. The next two tests of shoulder movement are best seen from behind.
Can you put both of your hands behind your head, please?
This tests abduction and external rotation.
And now reach behind your back and reach up as far as you can between your shoulder blades with your hands.
This tests internal rotation. Proceed with full examination if you found pain, swelling or limitation of these movements.
Now can you bring your shoulder forward like that?
Demonstrate the range of motion in flexion.
As high as it will go. And back down to your side. And back up the way, like that.
And then extension and abduction observed from behind.
And back down to your side. This time, can you bring your arm out to the side as far as it will go?
During abduction, palpate the inferior pole of the scapula to determine the degree and smoothness of the scapular component of this motion. Measure shoulder rotation with the arm abducted and the elbow flexed.
Now with your arm by your side like that, can you move it out to the side?
This is external rotation.
And now reach behind your back, and again reach up as high as you can with your thumb.
Internal rotation is expressed as the highest spinous process that the patient can reach with their thumb.
Now, Omar, can you bring your arms up to the side like that for me? Hold them there and don't let me push them down.
Assess the ability of deltoid to abduct against resistance, comparing left with right. Also, check the patient's ability to initiate abduction against resistance with the arm down at the side.
I want you now to push out against my hand, Omar.
Weakness or pain in initial abduction suggests a rotator cuff problem. The next test is for subacromial impingement.
I'm now going to bring your arm all the way out to the side and up to your ear.
After passive abduction,
And now bring it back down slowly.
the painful arc occurs on controlled adduction.
Is it painful at any stage?
No.
In impingement, pain would be reported between 60 and 120 degrees of abduction.
Now, Omar, can you reach again around behind your back? With your hand now, I want you to push out against my hand.
In this position, subscapularis is isolated as the only muscle contributing to internal rotation.
Relax.
Next, we test the external rotators, infraspinatus and teres minor, with the arm adducted.
Just flex your elbow up and bring your arm out. Now push out against my hand as hard as you can.
With the shoulder adducted and in 30 degrees of flexion, the contribution of deltoid is limited.
Thank you very much.
Hello, Abby. My name's Amy. Would it be okay if I examine you?
Yes.
Inspect the neck from the front, looking for a goiter.
Could I ask you to confirm your name and address?
The voice can be characteristically slow in severe hypothyroidism.
Please, could you hold your hands out for me?
Look for fine tremor and feel for sweating, which may occur in hyperthyroidism. Carpal tunnel syndrome can complicate myxedema, and you may see hand changes of thyroid acropatchy. Assess pulse rate, rhythm and volume. Tachycardia and atrial fibrillation can be features of thyrotoxicosis.
Keeping your chin still, could you look at my finger and follow it down?
Check for lid lag. You may need to give a bigger target if the patient's vision is poor. Look for proptosis. This is best seen from above. The thyroid or a thyroid mass moves up on swallowing. Supply water for the patient to sip to demonstrate this.
Please, could you take a sip of the water?
Observe the neck from the front during swallowing.
I'm gently going to examine your neck.
Stand behind the patient and gently feel the regions of the thyroid gland. Then place your hands over the gland with the index fingers just touching.
Could you take a sip of water for me, please?
Feel the gland as it moves up and then back down during swallowing.
Thank you.
Note the size, shape and consistency of any goiter and feel for a thrill. Listen over the two major lobes for a bruit. If there's a large goiter, use a tape measure and record the maximum neck circumference. Lastly, look at the legs for pretibial myxedema.
Thank you. Hello, Omar. My name is Amy. May I examine you?
Yes.
On general examination, note if the patient looks unwell, breathless, cyanosed, frightened or distressed, or has any scars.
Please, could I see your hands?
Signs in the hands may include tobacco staining, peripheral cyanosis, splinter hemorrhages, Janeway lesions, Osler nodes, and finger clubbing. Cardiovascular causes of clubbing include cyanotic congenital heart disease and bacterial endocarditis.
Thank you.
To examine the radial pulse, place the pads of your 3 middle fingers over the right radial artery at the wrist. Assess the rate, rhythm and volume. Count the pulse over 30 seconds and multiply by 2 to obtain beats per minute.
Do you have any pain in your shoulder?
No.
To detect a collapsing pulse, first check that the patient has no shoulder or arm pain or restriction on movement. Feel the pulse with the base of your fingers, then raise the patient's hand above their head. Palpate both radial pulses simultaneously, assessing any volume differences or delay. To measure the blood pressure, the patient should lie or sit and rest with the arm comfortably supported at about heart level and free of tight clothing. Position an appropriately sized cuff with the centre of the bladder over the brachial artery. Palpate the brachial pulse, which is medial to the biceps tendon, and inflate the cuff. The point at which the pulse becomes impalpable is a rough estimate of the systolic pressure. Inflate the cuff by a further 30 mm of mercury, then listen over the brachial artery with the stethoscope diaphragm. With the cuff inflated above systolic pressure, you should not hear anything. Slowly reduce the cuff pressure by 2 to 3 mm of mercury per second. Note the reading when you start to hear a regular tapping sound. This is the systolic pressure. Continue to deflate the cuff slowly. The point at which sounds are no longer heard is the diastolic pressure. More subtle features of the Korotkov sounds are described in the book.
I'm just going to press gently on your neck.
To feel the carotid pulse, lie the patient semi-recumbent. Only assess one side at a time. Gently place the tip of your thumb between the larynx and the anterior border of the sternocleidomastoid muscle. To look for the jugular venous pulsation, lie the patient supine at 45 degrees.
Could I get you to turn your head very slightly to the left-hand side?
Ensure the patient's head is resting comfortably to relax the neck muscles. Look across the neck from the right-hand side in good light. The JVP is the vertical height of the top of the pulsation above the sternal angle.
Do you have any pain in your tummy?
No.
If uncertain, use the abdominojugular reflex or occlusion to identify the JVP.
I'm just going to have a look in your eyes.
Look for xanthelasma, corneal arcus and conjunctival pallor.
Could you open your mouth for me? And lift up your tongue.
In the mouth, look for central cyanosis and dental caries.
Thank you.
Inspect the precordium with the patient sitting at 45 degrees and the shoulders horizontal. Look for surgical scars, visible pulsations and chest deformity. Lay your hand flat over the precordium to obtain a general impression of the cardiac impulse. Locate the apex beat by laying your fingers on the chest parallel to the rib spaces. It's normally in the fifth interspace at or medial to the midclavicular line. Note its character.
Could you take a deep breath in, breathe out and hold.
Feel for a right ventricular heave with the heel of your hand in the left parasternal area.
Breathe normally.
Feel for thrills with the flat of your fingers at the apex and both sides of the sternum. A thrill is a palpable vibration. If you subsequently hear a murmur on auscultation, go back and feel for a thrill in order to grade it. The stethoscope bell emphasizes low-pitched sounds such as the normal heart sounds. The diaphragm is better for higher-pitched sounds. At each site, identify the first and second heart sounds. Assess their character and intensity. Note any splitting of the second heart sound. Feel the carotid pulse with your thumb to time any murmur. Concentrate in turn on systole and diastole. Listen for added sounds and then for murmurs. Soft diastolic murmurs are sometimes no more than a so-called absence of silence. Listen to the precordium systematically with the bell and then the diaphragm. Listen at the apex where you felt the apex beat. This is a good site to hear mitral murmurs. The lower left sternal border is the best place to hear the murmur of a VSD. The upper left sternal border is the best place to hear pulmonary valve murmurs, and the upper right sternal border is a good place to hear the murmur of aortic stenosis.
Please take a breath in and hold. Breathe normally.
Listen over the carotids with the diaphragm. You may hear the radiation of an aortic stenosis murmur or carotid bruits. Listen in the left axilla with the diaphragm. The pansystolic murmur of mitral regurgitation, often described as loud and blowing, can radiate here. Next, listen specifically for mitral stenosis with the bell at the apex.
Please could you roll onto your left-hand side?
This is accentuated in the left lateral position. It's a mid-diastolic rumbling sound which may follow an opening snap.
Please could you sit forward for me?
With the patient leaning forward, listen in held expiration.
Take a deep breath in and out and hold.
For the murmur of aortic regurgitation, best heard at the left sternal edge in the third or fourth intercostal space. Listen over both lung bases posteriorly with the bell for the crackles of pulmonary edema.
And in and out.
Examine for superficial edema over the sacrum, a common location when patients are bedbound. Use 2 fingers, press gently for a few seconds, and see if this leaves an indentation.
Please lie yourself flat.
Now examine the peripheral vascular system in the abdomen and legs.
I'm just going to put you flat.
Inspect the abdomen for visible pulsation or surgical scars. Palpate over the abdominal aorta. Remember, this is above the umbilicus. If the aorta is easily palpable, consider the possibility of an aneurysm. If in any doubt, arrange an ultrasound scan. A pulsatile mass below the umbilicus suggests an iliac aneurysm. Listen over the aorta for a bruit due to a stenosis. Also listen for renal artery bruits bilaterally. Renal artery bruits cannot be distinguished from those in adjacent vessels, such as the mesenteric arteries. Inspect the legs and feet, considering ischemia and venous insufficiency. Look for colour change, loss of hair, surgical scars, and feel for temperature differences in the feet. Pay particular attention to the position, margin, depth and colour of any ulceration. Look specifically between the toes and heels for ischemic changes. Also take care to inspect the balls of the feet, the heels and their posterior aspects, which can be pressure areas in bedbound patients. Palpate the lower limb pulses, beginning with the femoral pulses. Explain what you're going to do. The femoral pulse is felt below the inguinal ligament, about midway between the anterior superior iliac spine and the pubic tubercle. Use the pads of your extended index and middle fingers. This pulse can be difficult to feel in obese patients. Remember that the common femoral artery is frequently used for vascular access during percutaneous interventions. Simultaneously palpate the right femoral and right radial pulses to check for radiofemoral delay, a sign of aortic coarctation. Use the stethoscope diaphragm to listen for femoral artery bruits. A bruit is a rushing sound made by turbulent flow due to narrowing or irregularity of the vessel lumen. Remember that if a vessel is completely occluded, there will not be a bruit. Next, assess the popliteal pulses. The patient must lie relaxed on a firm, comfortable surface. Flex the knee to 30 degrees. With your thumbs in front of the knee and fingers behind, press firmly in the fossa. The popliteal artery is sometimes difficult to feel. If it's very easy to feel, there may be an aneurysm. Feel the posterior tibial pulse 2 centimeters behind and 2 centimeters below the medial malleolus of the ankle. Palpate using the pads of your middle 3 fingers. Feel midway down the dorsum of the foot, just lateral to the tendon of extensor hallucis longus for the dorsalis pedis pulse. Use a Doppler probe to measure the ankle brachial pressure index.
I'm going to lift your leg.
To perform Berger's test, the patient should lie supine. Raise the patient's feet and support the legs at 45 degrees to the horizontal for 2 to 3 minutes. Look for pallor on elevation and emptying or guttering of the superficial veins.
Can I get you to sit up and to swing your legs over the bed?
Pallor on elevation, followed by spreading redness or reactive hyperemia on dependency, is a positive result, implying significant peripheral arterial disease.
Thank you. Hello, Abby. My name's Amy. Is it okay if I measure your blood pressure?
Yes, no problem.
The patient should be rested and seated or lying down. The arms should be comfortably supported at the level of the heart and free from constricting clothing. Choose a cuff of appropriate size and place the centre of the bladder over the brachial artery. Normally, the right and left arm will give a similar result. Measuring over thin clothing should not affect the reading. Palpate the brachial pulse and inflate the cuff until the pulse becomes impalpable. Note this pressure as a rough estimate of the systolic blood pressure. Inflate the cuff by a further 30 millimeters of mercury and then listen with the stethoscope diaphragm over the brachial artery. There should be silence initially. Slowly deflate the cuff by 2 to 3 millimeters of mercury per second. Note the pressure at which the regular tapping Korotkoff sounds appear. This is the systolic pressure. Continue to slowly deflate the cuff until the sounds disappear. This value is the diastolic blood pressure. More detail about Korotkoff sounds are in the text.
Thank you. Hello, Omar. My name's Amy. Would it be okay if I examined you?
Yes.
Make a general inspection of the patient's demeanour, body mass, any chest deformity or scars, and whether they're confused or distressed. Look for equipment such as inhalers or oxygen support. Measure the respiratory rate and observe the respiratory pattern. Note any unusual effort or noise in breathing such as stridor. Assess the radial pulse and check the blood pressure.
Could I have a look at your hands?
Look at the hands for tobacco staining, peripheral cyanosis and finger clubbing. This is most commonly associated with lung malignancy, fibrosis or chronic infection. There are 4 features: loss of the normal angle between the nail and the nail bed, increased nail bed fluctuation, increased bulk of soft tissue over the terminal phalanges, and increased nail curvature in later stages. Hypertrophic pulmonary osteoarthropathy includes finger clubbing,
Is this sore?
No.
and also painful swelling of the wrists and ankles. Check for tremor in the hands.
Could you hold your hands out for me? Bend your wrist back.
Watch for a few seconds. A coarse flapping tremor is seen with severe ventilatory failure and carbon
Thank you.
dioxide retention. Look at the neck for accessory muscle use and for the JVP.
Could you open your mouth for me?
Look at the tongue and lips for central cyanosis.
Thank you.
To detect lateral shift of the trachea, Gently place the tip of your right index finger into the suprasternal notch. This can be uncomfortable, so be gentle and explain what you're doing. The distance between the suprasternal notch and cricoid cartilage is normally 3 to 4 finger breadths. Feel for a tracheal tug, which may be found in severe hyperinflation.
Please can you take a deep breath in?
Use your hands to detect chest expansion, which should be symmetrical. Watch how your thumbs move. Reduced expansion indicates abnormality on the same side. Percussion allows you to hear the pitch and loudness of the percussed note and feel for post-percussive vibrations. Percuss sequentially over corresponding areas on both sides of the chest. Percussing over normal lung produces a resonant note. Over solid structures, for example the liver or heart, a dull note is produced. Place the palm of your left hand on the chest with your fingers slightly separated. Press the middle finger of your left hand firmly against the chest, aligned with the rib, over the area to be percussed. Strike the center of the middle phalanx of your left middle finger with the tip of your right middle finger. Use a loose swinging movement of the wrist. Remove the percussing finger quickly so the note generated is not damped. Work down the chest from side to side, comparing left with right.
Please could you take deep breaths in and out with your mouth open?
Most sounds are best heard with the bell. Auscultate left and right alternately, comparing equivalent positions, to ensure that localized abnormalities are not missed. Don't ask the patient to take exaggerated breaths for a prolonged period, as this may cause dizziness or even tetany. Listen anteriorly from above the clavicle down to the 6th rib and laterally from the axilla to the 8th rib. Avoid auscultation within 3 centimeters of the midline, as these areas may transmit sounds directly from the trachea or main bronchi. Assess the quality and amplitude of the breath sounds. Identify any gap between inspiration and expiration and listen for added sounds. Bronchial breathing is a high-pitched breath sound with a hollow or blowing quality similar to that heard over the trachea during tidal breathing. Bronchial breath sounds are found when normal lung tissue is replaced by uniformly conducting tissue and the underlying major bronchus is patent. This happens with pulmonary consolidation from pneumonia, at the top of a pleural effusion, and over areas of dense fibrosis.
Please could you say 111 each time I put my stethoscope on your chest?
111 111.
Over normal lung, the low-pitched components of speech are heard and high-pitched components are attenuated. Over consolidated lung, in pneumonia for instance, the numbers are clearly audible. Over an effusion or area of collapse, they'll be muffled.
111.
Whispering is not heard over normal lung, but in consolidation the sound is transmitted, producing whispering pectoriloquy.
111.
Auscultate each side alternately, comparing findings over a large number of equivalent positions.
111. 111. 111. 111.
Next, examine the neck and chest from behind.
Please could you sit forward for me and swing your legs over the edge of the bed? Could you look straight ahead? I'm going to examine your neck.
Examine for cervical lymphadenopathy. Systematically work your way through the lymph node groups. Start anteriorly with the submental and submandibular, and then the upper, middle and lower cervical nodes. also palpate the posterior triangle along the border of the trapezius muscle and the supraclavicular fossa. The post-auricular nodes are felt behind the ear, and the scalene nodes are above the first rib.
Please could you tilt your head to the right?
This helps relax the sternocleidomastoid, allowing you to palpate behind the clavicle.
And again to the left.
Place your index finger between the clavicle and the sternocleidomastoid muscle and press down gently onto the first rib.
Thank you.
Inspect the chest from the back, looking for deformities of the spine or chest wall or thoracotomy scars. Repeat the assessment of chest wall expansion posteriorly. Place your fingers along the ribs and watch your thumbs to track the motion.
Thank you. Could you cross your arms in front of your chest?
Percuss the chest posteriorly. For the superior part of the posterior chest wall, ask the patient to fold their arms, abducting the scapulae. Do not percuss near the midline, as a dull note is produced from the solid thoracic spine and paravertebral muscles. Map out any abnormal areas by percussing from resonant to dull. A pneumothorax will produce a hyperresonant note. Percussion over a solid organ or consolidated lung produces a dull note. Fluid, such as a pleural effusion, produces a very dull note described as stony dull. Basal dullness due to elevation of the diaphragm is easily confused with pleural fluid.
Please could you take deep breaths with your mouth open?
Repeat auscultation on the back. Again, compare left with right and listen at a good number of positions to ensure you don't miss a localized abnormality. As well as breath sounds, you may hear added sounds. The most common are crackles, wheeze and rubs. Crackles are interrupted non-musical sounds and can result from a number of different pathologies. Concentrate on when they occur in the respiratory cycle and their character, whether fine, medium or coarse. Sometimes added sounds can be due to bubbling in secretions in the larger airways. If you suspect this, remove your stethoscope and ask the patient to cough. Secretions in larger airways will be cleared. Crackles caused by disease of bronchioles or alveoli will not be affected. Wheeze has a musical quality and implies airway narrowing, commonly in asthma and chronic obstructive pulmonary disease. Time the sounds in relation to the respiratory cycle. Wheeze tends to be louder on expiration. Inspiratory wheeze implies severe airway narrowing. The loudness of wheeze is not useful in determining the severity of airway obstruction. In the most severe bronchospasm, the chest may be silent. Measuring the peak expiratory flow rate is a bedside test and an important part in the assessment of asthma.
Each time I put my stethoscope on your chest, please could you say 111?
One, one, one. 111.
We have discussed how increased vocal resonance can demonstrate sound transmission through consolidated lung. The other sound that you may come across during auscultation is a pleural friction rub. This is a creaking sound similar to that produced by bending stiff leather or treading in fresh snow. It is produced when inflamed parietal and visceral pleural layers move over one another. A rub is best heard with the stethoscope diaphragm. It may be heard only on deep breathing at the end of inspiration and beginning of expiration. A rub is normally associated with pleuritic pain and may be heard over areas of inflamed pleura in pulmonary infarction, vasculitis or pneumonia. If the pleura adjacent to the pericardium is involved, a pleuropericardial rub may be heard. Pleural friction rubs disappear when an effusion separates the pleural surfaces.
1 1 1 1 1 1.
Thank you. Please could you swing yourself back round and lie again on the bed.
Lastly, examine the legs for edema, signs of deep venous thrombosis or erythema nodosum.
Thank you.
Hello, Abby. My name's Ben. Do you mind if I examine your hands?
No.
See that the patient is comfortable and in a good position for examining the hands. There are many signs to look for. Erythema in acute inflammation. Synovitis can produce swelling of the metacarpophalangeal and interphalangeal joints. Look for deformities such as arachnodactyly in Marfan syndrome or a rotational deformity after phalangeal fracture. Are there mallet, boutonniere or swan neck deformities? Dupuytren's contracture can cause fixed flexion of the metacarpophalangeal and interphalangeal joints of the ring and little fingers. Look for subluxation and deviation of the wrist and metacarpophalangeal joints seen in rheumatoid arthritis. Also check for extra-articular signs of disease, such as small muscle wasting, vasculitis. Examine the proximal extensor surface of the forearms for rheumatoid nodules.
Just going to feel along your fingers. Let me know if it's sore.
Palpate along each finger for swelling or tenderness. Hard swellings are normally bony outgrowths called osteophytes, characteristic of osteoarthritis. They're called Heberdens or Bouchard's nodes when they occur at the distal interphalangeal and proximal interphalangeal joints respectively. Hard swellings may also be due to mucous cysts or rarely tumours. Soft swellings suggest synovitis. Detect synovitis in interphalangeal joints by gently pressing with your thumb and index finger above and below the joint to detect sponginess. Palpate around the wrists for swelling or tenderness. Osteophytes at the thumb carpo-metacarpal joint can cause squaring of the wrist.
Just going to gently squeeze your hand. Again, let me know if it's sore.
Gently squeeze across the metacarpal heads to test for sponginess or tenderness. Palpate the flexor tendon sheaths in the hands and fingers to detect local swellings or tenderness. Also feel for thickening in the palmar fascia. If you detect any swelling, look for triggering or locking during extension of a flexed finger. Next, we examine movement in the wrist and hands.
Can you just make a fist for me and straighten your fingers out?
To detect crepitus, place your index finger across the dorsum of the patient's fingers while they flex and extend them.
And now I'd like you to bring your hand up like that, and then down, and from side to side. And the same on this wrist.
These are active movements of the wrist, but be aware that gravity
Down.
contributes to the flexion.
And from side to side. And make a fist for me, please.
With the fingers flexed, look in the valleys in between the knuckles. They can be lost in the swelling of synovitis.
And now can you stretch your fingers out?
Lack of full extension may indicate tendon rupture.
And I'd like you to squeeze my fingers.
Test grip strength with 2 fingers inserted into their palm.
And now touch each finger with your thumb, like so.
Thumb opposition for pincer grips to demonstrate fine motor function in the hand.
And just let me move your fingers.
Investigate flexor tendon sheath abnormalities by passive movements of the fingers to see if you can elicit triggering or crepitus. Triggering is caused by nodular tendon thickening or fibrous thickening of the tendon sheath.
And the same on this hand.
The finger tends to jam in a flexed position and requires an external or passive extending force in order to straighten.
And now can I ask you to press your hands together like that and make a prayer sign?
This tests the range of passive wrist extension.
And now flex them the other way.
And extension. Look for symmetry of the elbow and shoulder positions. The normal range is 90 degrees in each direction.
Thank you very much. Hello, Abby. My name's Ben. Can I examine your hands?
Yes.
Just hold them out in front of you on the table.
Look for muscle wasting,
And roll them over for me.
particularly in the thenar and hypothenar eminences. Then test the function of the nerves in turn, starting with the median nerve.
And with your right hand, lay it completely flat on the table, keeping your thumb close to your palm, point it up towards the ceiling,
Test for power in thumb abduction.
and relax. And now touch the tip of your thumb with the tip of your little finger. Make a pincer grip. Don't let me break it.
And power in opposition.
And relax.
Next, we test the muscles supplied by the ulnar nerve.
And roll your hand back over. And now I want you to grip the card between your little and ring finger and stop me from pulling the card away.
Testing adduction of the little finger.
Relax. And now I want you to push out with your index finger against my index finger.
And abduction of the index finger.
I want you to grip the card, like me, with the sides of your thumbs and your index fingers, and don't let me pull it away.
If adductor pollicis is weak, the patient will flex the thumb in order to grip the card. Next, we test radial nerve motor function,
Can I take this hand?
starting with finger extension.
Now push your fingers out straight against me.
Then wrist extension,
Now push your hand up against me.
and finally thumb extension.
Now point your thumb up towards the ceiling and stop me from pushing it down.
Next, we test the sensory functions.
And now rest your hand on the table with the palm facing up. Can you feel me touching you there?
Supplied by the ulnar nerve,
And there?
the median nerve,
And roll your hand over.
and the radial nerve.
And can you feel me touching you there?
Yes.
Thank you very much. Hello, Omar. My name's Ben. Do you mind if I examine you?
No.
With the patient adequately exposed, look for asymmetry. Inspect both proximally and distally. Note any deformities such as clawing of the hands. Look for muscle wasting or hypertrophy, fasciculation or involuntary movements. Fasciculations are often elicited by flicking the skin over a muscle.
Just let your arms go floppy for me.
To test tone in the upper limb, hold the patient's hand as if shaking it. Use your other hand to support their elbow. Rotate the forearm, flex and extend the wrist, elbow and shoulder, varying the speed and direction of movement. Muscle tone is the resistance felt by the examiner when moving a joint passively.
Again, let this arm go floppy.
Always compare sides. Muscle tone can be pathologically decreased or increased. There are two principal types of hypertonia: spasticity and rigidity. Next, examine the deep tendon reflexes. The biceps jerk mainly incorporates the C5 nerve root.
And relax.
Use your finger or thumb to palpate the biceps tendon. To test the supinator or brachioradialis jerk, the forearm is in the mid-prone position and you strike the tendon overlying the distal end of the radius. Move the patient's arms to allow a good approach to the triceps tendon. This reflex involves C6 and C7. Eliciting reflexes and deciding if they are normal requires practice. Use reinforcement whenever a reflex appears to be absent.
You're going to strike your arm again. When I tell you to, clench your teeth, but not before I tell you to. Clench.
For the upper limb, ask the patient to clench their teeth or make a fist with the other hand.
Relax the hand.
For the finger jerks, place your middle and index fingers across the palmar aspect of the patient's proximal phalanges. Tap your own fingers with the hammer.
Relax.
And look for flexion of the patient's fingers. To test the Hoffman's reflex, place your right index finger under the distal interphalangeal joint of the patient's middle finger. Using your right thumb, flex their distal phalanx downwards and look for the pathological flexion response in their thumb.
Can you hold your arms up by your side like that for me, please? Stop me from pushing them down.
Power in abduction.
Stop me from pushing them up.
And adduction.
Now hold them out in front of you like that. Stop me from pulling them away.
Elbow flexion.
Stop me from pushing them in.
And extension.
Now place your arms out in front of you and spread your fingers. Stop me from pulling your fingers together.
Abduction of the fingers by the dorsal interossei and adductor digiti minimi.
Now I want you to grip my fingers and prevent me from pulling them away.
Use your index and middle fingers inserted from the thumb side to test grip strength.
And relax.
Now test coordination.
Now can you place your arms out in front of you, please? And hold them in the same position.
To elicit rebound, push the patient's wrist quickly downwards and watch the returning movement.
And relax.
The finger-nose test.
Now take the index finger of your right hand and place it on your nose. Touch my index finger on your nose and do that rapidly for me, please. I'm now going to start moving my finger. I want you to follow it. Now do the same with your left hand.
Start slowly with the explanation before asking the patient to speed up.
I'm now going to start moving it.
If they perform well, then begin to move your finger. Look for past pointing or intention tremor that would indicate cerebellar disease.
And relax.
Test the ability to make rapid alternating movements.
I want you to alternate with your right hand, front and back, like that.
Impairment of rapid movements like this is dysdiadochokinesis.
Stop. Now do the same with your left hand.
Evident as slowness, disorganization and irregularity of movement, also a feature of cerebellar disease.
Relax. Now I'd like you to pretend you're drinking a cup of tea on a saucer.
Apraxia is difficulty performing a motor task despite the patient understanding it and in the absence of motor weakness, cerebellar, extrapyramidal or sensory impairment.
Now I'd like you to copy those shapes and then write a sentence.
Inability to draw a geometric figure is called constructional apraxia and is a feature of parietal lobe disturbance. Writing a sentence requires intact language function as well as fine motor control of the hand. Dysgraphia is normally due to a dominant parietal lobe lesion.
Now could you put on your jumper?
Dressing apraxia is often associated with spatial disorientation and neglect. It is usually due to a non-dominant hemisphere parietal lesion.
And relax. Thank you. Hello, my name's Ben. Do you mind if I examine you?
No.
Consider the patient's nutritional state. Record their height, weight, waist circumference and calculate the BMI. Look for nail signs such as leukonychia or koilonychia.
Turn them over for me.
Palmar erythema is a sign of chronic liver disease, although it is normal in pregnancy. Look for finger clubbing, which can be due to chronic liver disease, inflammatory bowel disease or malabsorption.
Could you place your arms up in front of you and cock your wrists back, please?
Asterixis is a coarse flapping tremor seen in liver failure. It may also be seen in cardiac, renal and respiratory failure with CO2 retention. Look for needle tracks, tattoos and paucity of axillary hair. More than 5 spider nevi in the distribution of the superior vena cava is a sign of chronic liver disease, although again this can be normal in pregnancy. Remember to include the upper back. You'll need more exposure than is demonstrated here. Palpate for cervical node enlargement, which may be present in lymphoma or metastatic disease. Bilateral parotid swelling can be a feature of chronic alcohol abuse.
Bring your legs back up. Just rest your head back.
Look for spider nevi in the face and pallor and jaundice in the eyes.
I'm going to look in your eye. Look up for me.
Under natural light.
And down.
Jaundice is a diffuse yellow discoloration of the sclera.
Now can you open your mouth?
Look for angular stomatitis and mouth ulcers. Also inspect the teeth. You may smell a characteristic fetor.
And stick your tongue out.
The tongue can be affected by iron, B12 or folate deficiencies.
I'm just going to lie you flat.
Examine the abdomen with the head supported on a pillow to relax the abdominal muscles and with the arms by the sides. Expose from the xiphisternum to the pubic symphysis and look for scars, stomata, distension or pulsations.
Do you have any pain anywhere?
No.
I'm just going to feel very gently. Let me know if it's sore.
Ensure that your hands are warm and kneel beside the bed. Use your right hand, keeping it flat in contact with the abdominal wall, and avoid using your fingertips. Watch the patient's face throughout the examination for any sign of discomfort.
I'm now going to feel deeper. Again, let me know if it's sore.
Feel each region of the abdomen in turn with superficial palpation, then repeat with deeper palpation. If the patient reports a site of tenderness, begin distant from this and work towards it. In addition to feeling for tenderness and masses, assess the muscle tone.
Now can you take some deep breaths in and out?
Feel for the liver edge as it descends during inspiration. Start in the right iliac fossa and work superiorly 1 centimetre at a time. If the liver is palpable, describe its characteristics and the edge. Locate the upper border of the liver by percussing down from the 5th intercostal space in the midclavicular line. Measure the distance in centimetres from the upper border of dullness to the liver edge. Feel for the spleen in a similar fashion.
Again, can you take some deep breaths in and out?
Starting near the umbilicus and working up towards the left hypochondrium. If you don't feel the spleen, explore the length of the costal margin as its position is variable.
Can you roll onto your right-hand side, please?
If you have still not felt the spleen, repeat this examination with the patient in the right lateral position.
Take some deep breaths in and out again for me, please.
Again, palpate using your right hand, starting at the umbilicus and working towards the left hypochondrium. Place your left hand behind the patient's left ribs, gently pulling the rib cage forward.
And roll back onto your back.
Percuss over the lower ribs and lateral chest wall to confirm or exclude the presence of splenic dullness. To detect lesser degrees of kidney enlargement, place one hand behind the patient's back below the lower ribs and the other anteriorly. You sometimes need to press firmly, but take care as this may be tender. The kidney is typically ballottable.
Can I ask you to sit forward, please?
With the patient sitting up, you can palpate the renal angles directly, but take care if there is any tenderness.
Let me know if it's sore.
The renal angle is between the 12th rib and the lumbar vertebrae.
Now I'm going to tap your back. Again, let me know if it's sore.
If palpation is non-tender, gentle percussion with the closed fist may elicit tenderness. Check for pitting edema over the sacrum by applying pressure for a few seconds and seeing if indentation remains.
Can you lie down flat again for me, please?
Percuss from superior to inferior in the midline over the abdomen. The point at which resonance changes to dullness marks the top of the bladder. Percuss for ascites by starting in the midline and working laterally towards the flanks. With ascites, there will be dullness laterally.
Can I get you to roll onto your left-hand side?
Turn the patient and wait. A note change from dull to resonant is shifting dullness, indicating ascites.
And could you roll back for me? And now can you place your hand down the middle of your tummy?
A transmitted fluid thrill is another way to demonstrate gross ascites. The patient's hand prevents transmission of the impulse through their skin. Next, use the stethoscope diaphragm to auscultate for bowel sounds. The gurgling sounds of normal peristalsis are usually present every 5 to 10 seconds, but you need to listen for at least 2 minutes before concluding that they are absent. Listen over the kidneys for the bruit of renal artery stenosis and over the liver, where a bruit may be caused by hepatitis or hepatoma, and over the umbilicus for an arterial bruit that might suggest an atheromatous or aneurysmal aorta. Warn the patient before testing for succussion splash.
I'm going to give your tummy a shake.
An audible splash more than 4 hours after oral intake indicates delayed gastric emptying due either to gastric outlet obstruction or gastroparesis. Inspect the legs for pyoderma gangrenosum and for ankle edema, which may be due to hypoalbuminemia. Although not demonstrated here, you should also examine the hernial orifices and genitalia.
Thank you very much. Hello, Omar. My name's Ben. Do you mind if I examine your back?
No.
Can I ask you to stand up, please, and face me?
With the patient standing and adequately exposed, inspect from in front, the side and from behind. Note any deformity, for example, abnormal curvature. Look for soft tissue abnormalities, such as hairy patch or lipoma, that might overlie a congenital abnormality.
I'm now going to feel down your back. Let me know if it's sore anywhere.
Palpate the midline spinous processes. Note the overall alignment and any focal tenderness. Increased prominence of one or more posterior spinal processes can be due to collapse of the vertebral body anteriorly. The L4-5 interspinous space is at the level of the iliac crest.
And again, let me know if it's sore.
Feel for tenderness in the paraspinal muscles. You may also notice areas of increased tone.
Now I'm going to tap over the bottom of your back. Let me know if it's sore.
After warning the patient, lightly percuss the spine with your closed fist and note any tenderness.
Just sit down on the couch for me and cross your arms. And now I'd like you to look towards me, rotate towards me.
With the patient sitting, the pelvis cannot rotate. Look for rotation between the shoulders and the pelvis. Almost all of this occurs in the thoracic spine. Next, flexion, most of which happens in the lumbar spine.
I'd like you to keep your legs straight and bend over to touch your toes.
Record how far down the legs the patient can reach.
And take a step forward. Now, lean back as far as you can.
Extension, again mostly lumbar. Normal is 10 to 20 degrees beyond vertical.
Now face me. And now I'd like you to go down to the side like that as far as you can.
This tests lateral flexion. Ask the patient to reach down each side, touching the outside of the leg as far down as possible, keeping the leg straight.
And turn round.
When examining forward flexion of the spine, it is difficult to separate this from hip flexion. In Schober's test, we isolate the component in the lumbar spine. Mark the skin in the midline at the level of the dimples of Venus. Use a tape measure to draw two more marks, one 10 centimeters above and one 5 centimeters below the initial mark. We refer to the upper mark as B and the lowest mark as C. Place the end of the tape measure on the uppermost mark B and ask the patient to bend forward and touch their toes.
Now, keeping your legs straight, bend over to touch your toes.
The distance between B and C should increase from 15 centimeters to more than 20 centimeters. Now we move on to the straight leg raise to test for tension in the L4, 5 and S1 nerve roots. With the patient lying supine, lift the foot to flex the hip passively, keeping the knee straight.
Tell me if you get any pain at any stage.
Determine if there is a limit caused by pain in the thigh or leg. It's normal to reach 80 or 90 degrees from the couch. If a limit is reached, support the limb just below the limit.
I'm just going to bring your foot up. Let me know if that causes any discomfort.
Pain due to nerve root tension should be reproduced by dorsiflexing the foot. For the tibial nerve stretch test, flex the knee and hip.
I'm now going to bring the leg up again.
Then gently extend the knee so that the tibial nerve bowstrings across the popliteal fossa.
Let me know if it's painful.
Press over the hamstring tendons at either side.
Is that sore?
No.
And then over the nerve in the middle of the fossa. The test is positive if pain occurs when the nerve is pressed, but not the hamstring tendons.
Now could you roll over onto your front?
Lie the patient prone for the femoral nerve stretch test.
I'm just going to bring this leg up.
Flex the knee and then extend the hip. This stretches the femoral nerve.
I'm going to lift this leg. Let me know if there's any pain.
A positive test causes pain in the back or front of the thigh.
And roll over again. Thank you very much.
GALS stands for Gait, Arms, Legs and Spine. The GALS screen is a rapid musculoskeletal, neurological and functional assessment. Ask about pain or stiffness in the muscles, joints or back, whether they can dress themselves without difficulty, and if they can walk up and down stairs without difficulty. If all three answers are okay, there's unlikely to be a significant problem. Ask the patient to undress and stand in front of you.
Could you walk towards me?
Ask the patient to walk ahead in a straight line for several steps, turn around and walk back.
Could you do that again for me, please?
Watch from both in front and behind, looking for smoothness and symmetry of the gait.
Could I have a look at your back?
Palpate for hyperalgesia in the belly of the supraspinatus muscle.
Is that sore?
No.
Hyperalgesia here is a typical finding in fibromyalgia.
How about that?
No.
When asking a patient to exhibit movements, it's often simpler to demonstrate actions rather than only telling them what to do.
Please copy the movement I make with my arms.
This position, with the hands behind the head and the elbows going back, tests abduction and external rotation of the glenohumeral joint. With the elbows at the side of the body, bend them at 90 degrees. Ask the patient to demonstrate the range of pronation and supination. Bringing the hands up to touch the shoulders requires elbow flexion. Opposing the fingers and palms in a prayer sign extends the wrists. Put the backs of the hands together similarly to demonstrate wrist flexion. Put the arms straight out in front of the body to demonstrate elbow extension. Ask the patient to make a fist and open the hand flat, testing the hand and wrist. Look for complete extension of all the finger joints.
Please relax your arms.
Ask the patient to squeeze your index and middle fingers, testing their power grip.
Please make a pincer grip. And don't let me break it.
Test the ability and strength of thumb and index finger opposition.
Please touch each finger to your thumb.
This demonstrates precision grip, coordination and concentration. Gently squeeze the patient's metacarpal heads. Tenderness suggests inflammation involving the metacarpophalangeal and proximal interphalangeal joints caused, for example, by rheumatoid arthritis.
Is this sore?
No.
The next section is the legs. Ask the patient to lie supine on the couch and adjust it as necessary. Remember that some parts of lower limb examination may risk dislocation of a total hip replacement, so examine with care. Start with Thomas's test for fixed flexion deformity of the hip, testing hip extension if you like. With the patient lying supine, you can see that he can't extend his hips any further because of the couch supporting his knees and ankles. When performing Thomas's test, we flex the lumbar spine and pelvis so that hip hyperextension is required to put the lower limb flat on the couch. Your left hand in the small of the patient's back will detect when the lumbar lordosis is straightened.
I'm going to bend your knees.
Flex both hips as far as they'll go, feeling the lumbar spine flattening against your left hand.
Could you straighten your left leg for me?
Putting the left lower limb flat on the couch with the lumbar spine still flexed shows a few degrees of hyperextension of the left hip. In fixed flexion deformity, the limb will remain elevated or curvature will return to the spine.
Could you bend your knee for me?
Examine the range of flexion in the hip and knee with your hand on the patient's knee. This allows you to feel for crepitus in the patellofemoral joint.
Could you bend this knee for me?
The normal limit of flexion is 120 degrees at the hip and 140 degrees at the knee.
Could you bend this knee for me?
Flex the patient's knee and hip to 90 degrees and passively rotate each hip internally and externally. Think about the anterior of the thigh when working out which direction is which.
Could you bend your left knee?
Be careful to do this test gently. It may be uncomfortable for the patient. Note any pain or restriction of movement. The normal range is 45 degrees in each direction. Palpate each knee for warmth and swelling. These are features of inflammation. Check for the patellar tap caused by knee joint effusion. With your left hand, gather the contents of the suprapatellar pouch into the joint. Look at the feet for any abnormality. Examine the soles looking for calluses or ulcers indicative of abnormal load bearing. Remember to look at the back of the heels, which are a site of pressure sores in bed-bound patients. Look at the alignment of the toes and gently squeeze the metatarsal heads together.
Is this sore?
No.
To see if there's any tenderness from inflammatory arthritis.
And this?
No.
I'm now going to examine your back. I'm just going to lower the couch.
Finally, the spine. We need the patient standing again. Lower the couch to a height that is safe for them to climb off.
Let me give you a hand up. Could you stand here for me, please? With your legs slightly apart.
Standing behind the patient, assess the straightness of the spine. Look at the symmetry and muscle bulk in the neck, upper limbs, trunk and lower limbs. Look for asymmetry in the level of the iliac crests, which may be due to leg shortening. Look for swelling or other abnormality of the gluteal, hamstring and calf muscles, and at the Achilles tendons and hindfoot regions for swelling or deformity.
Could you try and touch your toes?
Stand beside the patient while they bend down. As well as spinal flexion, look for exacerbation of scoliosis or limitation of hip flexion. Stand behind and hold the pelvis to stop it moving.
Could you turn from side to side?
This tests rotation movement happening mostly in the thoracic spine.
Could you slide your right hand down the outside of your right thigh towards your knee? And the same on your left side.
Testing lateral flexion, which occurs mostly in the lumbar spine.
Could you turn to face me? Can you try and put your right ear to your right shoulder?
Lateral cervical flexion.
And the same on your left. Look up at the ceiling.
Cervical extension.
And down to your chest.
And flexion.
Please look straight ahead. Can you open your mouth and move your jaw from side to side?
Testing function in the temporomandibular joint.
Thank you.
Hello, Omar. My name's Ben. Do you mind if I examine you?
No.
Can I ask you to stand up to begin with, please? Please, could you take some steps towards me, turn around and walk back?
Observe the gait, looking for symmetry and smoothness.
Now, could you just lift up your shorts for me?
From the front, look to see if the stance, shoulders and pelvis are straight. Is there deformity of the hip, knee, ankle or foot, or any muscle wasting? Assess the straightness of the spine and the bulk of the gluteal muscles. Note any scars, sinuses or skin changes over the joint.
Now, could you get back onto the couch?
Make sure that the patient and you are as comfortable as possible during any examination. Adjust the height of the couch if necessary.
I'm going to lie you flat.
The hip joint itself is not directly palpable.
Rest your head back. Just going to feel over your hips. Let me know if it's sore.
The greater trochanter may be tender in trochanteric bursitis. Although not shown here, the lesser trochanter and ischial tuberosity can also be palpated. Hip movements are tested passively. Take care to isolate the joint being tested. When testing flexion, the left hand is placed against the sacrum to detect any flexion at the lumbar spine.
And the same with the other side?
Lumbar spine flexion can contribute to apparent hip flexion, masking limitation. Normal range of flexion is from the neutral position here to 120 degrees.
Now I'm just going to bring your leg out to the side. Let me know if it's sore.
Again, use your left hand on the opposite iliac crest to stabilise the pelvis and isolate hip movements when testing abduction and adduction.
And we'll repeat the test on the other side.
Abduct the extended leg until you feel the pelvis start to tilt. The normal range is 45 degrees. Test adduction by moving the extended lower limb medially over the other one. The normal range is 25 degrees.
Just relax your leg.
Test rotation of the hip first with the leg in extension. Roll the leg on the couch using the foot to indicate the range of rotation.
And relax.
The normal range is 45 degrees in each direction. Painful or restricted rotation movements are common in osteoarthritis of the hip.
Just going to bring the leg up again.
Rotation is also tested with the hip in 90 degrees of flexion.
Again, let me know if it's sore.
In this position, the leg indicates the range of rotation, but can sometimes be confusing. This manoeuvre shows internal rotation.
And the same with this leg. Flex it up.
Watch the patient's face for discomfort. External rotation and internal rotation. In flexion, the normal range is also 45 degrees in each direction.
Could you roll over onto your front?
To test hip extension, we need some room posteriorly. Make sure that the couch is flat. Again, the left hand palpates the sacrum to detect movements out with the hip.
Just going to lift your leg up again.
Gently lift each leg in turn to assess the range of extension.
And the same with this leg.
The normal range is from neutral to 20 degrees of extension.
Now roll back over.
Now we show the special tests, starting with the Thomas test for fixed flexion deformity or limited extension.
My left hand underneath. And again, can I put my arm under your leg?
Flex both hips up as far as possible and feel that the lumbar lordosis is eliminated. From this position, we're testing the left hip.
Now straighten your left leg and put it flat down onto the couch.
Keep the non-test hip and the lumbar spine flexed while the patient extends the other limb.
And we'll do the same on the other side. Let me pop my hand under your back and bring your legs up.
Inability to get the test leg flat onto the bed indicates a flexion deformity.
And bring your right leg down, flat onto the couch.
Remember that extremes of hip movement may risk dislocation of a total hip replacement. The next special test is to examine for limb shortening.
If you just lift your vest up for me and pull your shorts down a touch.
The patient should have the legs stretched out as far as possible and in equivalent positions to eliminate any soft tissue contracture or abnormal posture.
Let's just straighten you. That's it.
Measure with the tape from the umbilicus to the medial malleolus. This is the apparent length and will include any lumbar spine deformity or angulation of the pelvis. Record and compare both sides. Measure the true leg length from the anterior superior iliac spine to the medial malleolus. There are many causes of true shortening of the leg listed in the book. If you detect any discrepancy in leg length, follow up with block testing. This is described in the book. The final test is Trendelenburg's sign for normal hip abduction function in weight bearing.
Can you just stand up for me, Omar?
Standing on one leg, the opposite iliac crest normally rises because of abduction of the weight-bearing hip by the gluteal muscles.
Now I'm going to ask you to stand on one leg. If you feel like you're going to lose your balance, use my arms as support, okay? Stand on your right leg.
Carefully watch or palpate the iliac crests to see if they move up or down. It may be necessary to hold the posture for 30 seconds to demonstrate early gluteal fatiguing, and there are many other causes of a positive Trendelenburg sign.
Hello, Abby. My name's Ben. Do you mind if I examine you?
No.
Could I ask you to stand up, please? And just face me.
Inspect the legs with the patient standing and walking. Look for scars, sinuses, redness or rashes. Look for abnormalities of posture and common deformities such as genu valgum or verum. Particularly look for quadriceps muscle wasting.
Now can you walk towards me, turn and walk back?
Look for gait asymmetry and at what happens to the knee during the stance and swing phases.
Could you sit back on the couch?
Make sure the patient has both legs well exposed so that you can compare sides. Quadriceps wasting is almost invariable with inflammation or chronic knee pain and develops within days. It's often useful to measure the thigh circumference with a tape measure. Do this 20 centimetres above the tibial tuberosity and compare sides. Feel the warmth of the skin overlying the joint, which will be increased if there's any inflammation. For the patellar tap, empty the suprapatellar pouch by sliding your left hand down the thigh to the patella. Keep your hand there and with the fingertips of your right hand press down briskly and firmly over the patella. For the ripple test, the knee and left hand are in a similar position. Empty the suprapatellar pouch and the medial side, then stroke the lateral side looking for a bulge or ripple on the medial side.
I'm now going to feel around your knee. Let me know if it's sore anywhere.
Palpate for the sponginess of synovitis either side of the quadriceps tendon. Then feel round the articular margin of the tibia. If there is tenderness, localize this as accurately as possible. Also feel the articular margin of the femur and the tibial tuberosity.
And the same on the other side.
The joint lines are most easily felt with the knee at 90 degrees. Focal tenderness may be due to a meniscal or collateral ligament injury. Isolated tenderness of the tibial tuberosity in adolescence may be due to Osgood-Schlatter's disease. Next, we look at movements of the knee joint. First, active movements.
Can you bend your leg up for me, please, Abby?
Here, the examiner's hand is feeling for
same on the other
crepitus.
side.
The normal range is from neutral to 140 degrees of flexion.
Now could you lift it straight off the bed?
When the patient performs a straight leg raise, look for extensor lag, inability to keep the knee straight.
Now let me flex the leg.
You would expect to find a similar range with passive movements. Full extension is when the tibia and femur are in longitudinal alignment and is described as 0 degrees.
And let your legs go floppy and let me take the weight.
With the patient relaxed, lift the heels to assess for any hyperextension or recurvation. Up to 10 degrees of symmetrical hyperextension is normal.
And just let me take the weight of your legs.
To test the collateral ligament stability, hold the ankle between your elbow and side. Use your thumbs to feel the joint line and assess the degree when the joint space opens.
And just bend it up a fraction.
If the knee is stable, repeat the process with the knee flexed at 30 degrees. In this position, the cruciate ligaments are not tight.
And the same on the other side. Just let me take the weight of the leg.
With your thumbs in position, apply first valgus and then a varus force. Major opening of the joint with the knee extended indicates collateral and cruciate injury.
And flex it up a little.
If the ligament is lax or ruptured, movement can occur, but this may not be painful. If the ligament is strained but intact, the test will be painful, but abnormal movement will be limited.
Now bend both of your legs up for me, please.
To examine cruciate ligament stability, flex the patient's knees to 90 degrees. Look for posterior sag, which might give a false positive anterior draw sign. Maintain the position of the patient's legs by sitting to trap their foot. Grasp the proximal tibia with both hands.
Just relax your hamstrings.
You can feel whether or not the patient is relaxed with your index fingers crossing the popliteal fossa. Abnormal forward movement suggests laxity or rupture of the anterior cruciate ligament. Abnormal posterior movement suggests a lesion affecting the posterior cruciate ligament.
Okay, I'm now just going to bend your leg up. Let me know if it's uncomfortable.
For the patellar apprehension test, start with the knee extended and press the patella laterally, then slowly flex the knee. Discomfort, apprehension, or active resistance suggests previous patellar dislocation or instability. The test for meniscal provocation starts with the knee flexed.
Again, just bend this leg up for me, please.
To stress the medial meniscus, externally rotate the foot and abduct the thigh. Smoothly extend the knee, keeping the foot in the midline, which creates a varus stress loading the medial compartment.
And bend it up again.
To stress the lateral meniscus, internally rotate the foot and adduct the thigh. Apply a valgus stress as you smoothly extend the knee, thereby loading the lateral compartment.
And let's do the same on the other side.
Externally rotate the foot and apply a varus stress to load the medial meniscus.
Bring it out to the side.
If a meniscal injury is present, a click or clunk may be felt or heard, which may be painful. And finally, to test the lateral meniscus, internally rotate the foot and adduct the thigh to create a valgus load on the lateral meniscus. The final part of the examination is the squat test.
Now could I ask you to stand up?
Ask the patient to squat, keeping the feet and the heels flat on the ground. This requires flexion at the knee.
Thank you very much. Hello, Omar. My name's Ben. Do you mind if I examine you?
No.
Expose the lower limbs as much as possible with regard to the patient's comfort and dignity. Look for asymmetry or deformities proximally and distally. Examine for wasting, hypertrophy, fasciculation, and involuntary movements. Sometimes fasciculation is elicited by flicking the skin over a wasted muscle.
Just want you to let your legs go floppy.
Examine the tone in the lower limb, first by rolling or rotating it from side to side, then by briskly lifting the knee to a flexed position. Tone can be increased or decreased, and there are various patterns of increased tone, such as spasticity and rigidity.
Just relax again.
Test for clonus at the knee joint with the patient relaxed and the knee extended. With your thumb and forefinger, sharply push the patella towards the foot. Clonus is a rhythmic series of contractions evoked by a sudden stretch of the muscle. A few beats of clonus is normal in healthy individuals. To elicit ankle clonus, support the patient's leg with both knee and ankle at 90 degrees. Briskly dorsiflex and evert the foot, sustaining the pressure. Next, we test the deep tendon reflexes.
Just let the leg go floppy over my arm.
The patient should be relaxed and comfortable. Anxiety or pain can increase the response. For this reason, we test the reflexes after tone but before power in the examination sequence. The knee jerk tests the L3 and L4 nerve roots. Compare both sides.
This time I want you to clasp your hands together. Grip when I say grip, but not before.
Use reinforcement if a reflex appears to be absent.
Grip.
When testing the lower limb reflexes, ask the patient to interlock the fingers and pull one hand against the other.
Grip.
This is the Gendrasic maneuver. The patient should relax between repeated attempts. Now, we test the ankle jerk reflexes. They use the S1 nerve root. This is a method to use with a recumbent patient. Next, the plantar response, a superficial reflex. Run a blunt object along the lateral border of the sole of the foot towards the little toe.
Just going to run this stick up the sole of your foot.
The normal response is flexion of the great toe and of the other toes. Next, systematically test power in the muscle groups of the lower limb.
Now lift your right leg straight up off the bed.
This shows the ability of hip flexors and knee extensors to overcome gravity.
And the same with the left leg.
Use the MRC scale from 0 to 5 to grade power. Test the same groups in isometric contraction against resistance.
And relax. And the same on the left side. Push up.
The hip flexors.
And relax.
And the knee extensors.
Now keep your legs straight as I try to bend it.
Always compare sides. Remember that strength can vary greatly with age and occupation.
And the same on the left side. Try to keep it straight. Now bend the leg up. And try to pull your heel towards your bottom as hard as you can.
This is testing power in the knee flexors.
Relax.
Make sure that whenever possible you use the same hand, posture and mechanical advantage to apply the force in order to make valid comparison.
Now point your toes up towards the ceiling and hold them there as I try to push them down.
Testing the ankle dorsiflexors and toe
The
extensors.
same on the left side. And don't let me push them towards you.
Plantar flexion at the ankle and toe flexion. Take care that you don't hurt the patient by inadvertently leaning on them or squeezing them with your other hand.
Now I want you to run your heel down your shin like this.
This is a test of muscular coordination called the heel-shin test. It is abnormal if the heel wavers away from the line of the shin due to cerebellar ataxia. Lastly, the abdominal reflexes.
Just pull your vest up for me, please. Just going to run a stick across your tummy.
Use an orange stick and stroke briskly but lightly in a medial direction across each quadrant of the abdomen. The normal response is contraction of underlying muscle with movement of the umbilicus.